The diagnostic workup for a patient with Waldenstrom's includes multiple different steps. And I think initially is the blood work. I think the blood work can give us a good idea of how the patient's status is. The most common manifestation in patients with Waldenstrom's is anemia, like in this case. Thrombocytopenia and leukopenia are also seen, but they are less common. Once we have that, we need to make sure that the anemia is actually related to the disease. There are many other causes for anemia, specifically in aging population. So we typically kind of rule out other causes of anemia, common causes of anemia, such as iron deficiency or vitamin B12 deficiency or folic acid deficiency. We always make sure that the patient has no evidence of hemolysis, which is destruction of their own red cells. And in this scenario, if all those tests were negative and we do a bone marrow biopsy that shows that there's an extensive involvement of the bone marrow space by this lymphoma, then it's easily attributable that the anemia is due to the disease. And the next step is actually evaluating the patient's serum IgM. In this case, the serum IgM is elevated. And it's elevated to the point that we could be concerned up to some degree of a condition called hyperviscosity. Hyperviscosity occurs when the viscosity of the serum gets to be so thick that can cause problems in the patients. Now, IgM is a large molecule, and as the IgM increases, the viscosity of the serum also increases. But there is not a linear relation between those two factors. Actually, the risk of hyperviscosity to be symptomatic starts at about an IgM of 3,000. And it kind of is logarithmic in that specific scenario. So 4, 5, 6,000 really is a much higher risk than 2,000 or 1,000 in that specific scenario. So in this patient, we have a viscosity of 3.7 centipoise and an IgM of about 4,700. So those are concerning for hyperviscosity. But really, the patient does not have classic symptoms of hyperviscosity, which include recurrent headaches, recurrent nosebleeds that are spontaneous and hard to control, slow mentation. And in this patient, for example, would be a patient in whom I would recommend having a formal retinal examination to make sure that there are not evidence of hyperviscosity that is asymptomatic. In the patient's retinas, we can actually see the vessels being engorged or being more tortuous than we would expect. In later stages, we can actually sausaging, like sausage link formation. And in clear cases of hyperviscosity, we actually see evidence of microhemorrhages in the retinal fundus. So I think this is in general the way we look at this. There are other patients who present with other conditions in patients with Waldenstrom's that makes it sometimes challenging to diagnose and treat, such as patients with neuropathy, patients with pleural effusions. There's a rare complication in which patients can have amyloidosis or leptomeningeal involvement by the disease called Bing-Neill syndrome. Those are very rare situations, and in those situations, I think seeing a specialist who see a large quantity of patients with Waldenstrom's could potentially be beneficial.